guess we'll get started now. For everybody here, I'm Dr. Khan. I'm one of the new pediatric heart failure transplant cardiologists here at Children's National, and I'm with Dr. Scheel.
I'm Janet Scheel. I'm the director of the heart failure transplant program. What we'd like to do today is go through a case presentation, and then my newest partner, who joins us from Cincinnati after an extra year of fellowship in heart failure and transplant, will talk about meeting our objectives for the conference. So next slide. So our objectives, just to review, are to be able to identify the different etiologies and presentations of pediatric heart failure, know the medications and their use for heart failure, and understand the indications for advanced mechanical circulatory support in these patients. Next slide. So our case presentation, next slide. We're going to talk about R.W., who was a 2-month-old male who presented with a 4-day history of poor feeding, fatigue, and grunting. His past medical history was pretty unremarkable. He had no fevers by history, and he also had no family history of cardiomyopathy. Next slide. He presented to an outside hospital with this history and was given a fluid bolus because of his poor feeding history, at which point his symptoms worsened. His chest X-ray showed cardiomegaly and pulmonary edema, and a bedside echo showed decreased ventricular function. He was transferred here to us. We thought this was a good case to start with, since it sort of brings up a lot of the issues that I know people worry about out in the community. It's so easy to mistake heart failure for some of the other things that are so common, particularly in infants who present with poor feeding and respiratory symptoms. And now I'm going to turn it over to my colleague, who will go through the diagnosis and evaluation of heart failure in pediatric patients.
And I just want to take a second to let everybody know that feel free to submit any questions at any point in time. I may defer to the end. We'll give about 10 to 15 minutes at the end to answer questions in case they get answered during the course of the presentation. So when trying to diagnose and evaluate pediatric heart failure, you can do next slide for me. I think it's really important to first know what is pediatric heart failure. It's really a clinical syndrome that occurs when the heart's unable to provide sufficient blood flow to the body to meet metabolic requirements or to accommodate for systemic venous return. In the pediatric population, there's a significant amount of different etiologies that can cause this, and it's a very diverse group, and that actually affects the presentation and the clinical symptoms that you see with heart failure. Next slide. One of the first and more foremost things that we think about is cardiomyopathies, and that's a structurally normal heart. Typically, there's 5 different classifications of primary cardiomyopathy. Most commonly, we see a dilated cardiomyopathy, which if you look in the cartoon, to drive home the point that you have an enlargement of all of your cardiac chambers and you have systolic dysfunction. That's the most common type and most of what we'll focus on in this presentation today. The second type is a hypertrophic cardiomyopathy, which actually gives you more of a diastolic dysfunction, which we will sort of defer as it's really a whole topic in and of itself. But this is the type of patient who comes in with concerns for sudden death in the athletic population. You have thickened left ventricular wall. Restrictive cardiomyopathies similarly have diastolic dysfunction, but they have a very stiff non-compliant ventricles, and that is the least common type. Left ventricular non-compaction is a newer form of cardiomyopathy, really only first described in the past 10 years or so, and has a variety of different clinical phenotypes. Most commonly is either a benign phenotype or a dilated phenotype. And then the 5th cardiomyopathy is not listed. It's called arrhythmogenic right ventricular cardiomyopathy, and really you get incessant ventricular arrhythmias. So it's a little bit different in your presentation and not the classic congestive heart failure type symptoms. Secondary cardiomyopathies are also really important to remember because a lot of these can be potentially reversible. Arrhythmogenic cardiomyopathies, as we mentioned, ischemic type, which are far more common in the adult population, toxic exposure, such as anthracyclines and some inborn errors in metabolism, as well as infiltrative, which are much more common in the adult population, such as sarcoidosis, amyloidosis, and infectious, which is something we do deal with a lot in the pediatric population, myocarditis and rheumatic fever. Next slide. Other things that can cause heart failure are congenital cardiac malformations, and they do this in a few different ways. First, we worry about volume overload, and this happens when you have a large left-to-right shunt, such as that of a VSD, or ventricular septal defect, or a PDA, a patent ductus arteriosus. Or if you have a large amount of atrioventricular or semilunar valve insufficiency, so if you had a bicuspid aortic valve with subsequent aortic regurgitation, or if a patient had tetralogy of Fallot, had repair, which inherently causes pulmonary regurgitation, you could have heart failure from those symptoms. Next slide. A third different way, or a second different way that congenital cardiac malformations cause heart failure is through pressure overload. And this is the classic patient who comes in, ductal dependent circulation with severe aortic stenosis or aortic coarctation, and they have a stun to their left side of their heart because it's got so much afterload to work against, and those patients present in heart failure as well. Or you could have right-sided obstruction, which causes right-sided heart failure, such as severe pulmonary stenosis. Next slide. Complex congenital heart disease, far less common, but something that we deal with in the cardiology world a lot more commonly. The single ventricle, such as those with hypoplastic left heart or an unbalanced atrioventricular septal defect, or even more rarely, the systemic right ventricle, those with congenitally corrected transposition of the great arteries, or CCTGA. Next slide. As you can see, there's a whole variety of different etiologies that cause the same or similar symptoms of decreased cardiac output. I show this schematic because this is sort of the pathophysiology of how heart failure presents, and also I will refer back to this later on when we talk about our targets of medications. As you can see, the reduced cardiac output causes sympathetic nervous system activation, which can cause vasoconstriction, causing cardiac remodeling, which adverse remodeling, which sort of perpetuates the cycle. In addition to that, sympathetic nervous system activation causes activation of your Renin-Angiotensin-Aldosterone System, which again causes adverse remodeling. All of this ultimately results in sodium and water retention, which increases your cardiac filling pressures even more, which again perpetuates the cycle. Next slide. So I think when you have a patient who comes in with the symptoms that we had in our case presentation, it's really important to think about heart failure and then to use your history and your physical exam to guide what type of etiology you might have, as they'll present very differently. So I think history is one of the most important things. Primary symptoms in children are obviously different than those in adults. Infants will often present with poor weight gain, failure to thrive, diaphoresis or respiratory distress with beads, whereas older children will often present with abdominal complaints of vomiting, abdominal pain, fatigue, or dyspnea on exertion, some shortness of breath, and occasionally non-vasovagal syncope. It's important to ask about the onset of symptoms. Myocarditis can present with a recent viral prodrome, and that's not something, that's a potentially reversible cause that you would, that we could offer better therapies for and better prognosis. I think the age of the patient is also very important to think about when you're evaluating a patient who's coming in with concern for heart failure. Is this happening in a neonatal patient where the ductus may be closing and you may be seeing the effects of a ductal dependent circulation, so an aortic coarctation or severe aortic stenosis? Is this patient in there a couple months old where they had a decrease in their pulmonary vascular resistance, and now we're seeing much more of a left to right shunt in a VSD or a PDA, and so now patients are more tachypnic and failing to thrive? Or potentially an ALCAPA or an anomalous left coronary artery coming off of the pulmonary artery, where you're not feeding your diastole. Because you're coming off of your pulmonary artery, you're not feeding the muscle of the heart with as high of a pressure, and that's when they tend to present. Or do you have a neonate who could be suffering from an inborn error of metabolism? Next slide. Another thing to think about is for secondary causes, to evaluate for secondary causes of heart failure, thinking about the comorbidities the patient might have. Failure to thrive could be resulting for a lot of different reasons, but important to note. Malignancy or a history of malignancy with anthracycline exposure could cause heart failure. You can get a dilated cardiomyopathy with certain neuromuscular diseases. Thalassemias or sickle cell patients who require frequent blood transfusions may get iron overload and have a restrictive type phenotype with a constricted stiff ventricle. Those with untreated thyroid disorders can have dilated cardiomyopathies. and those with end-stage liver disease can have a cirrhotic cardiomyopathy. And those, obviously, with known congenital heart disease can become progressive, such as a VSD, a PDA, or bicuspid aortic valve that becomes stenotic, or regurgitant, causing heart failure. Next slide. It's important to think about the family history because there are so many genetic cardiomyopathies that run in families. Is there a family history of cardiomyopathy? Patients may never, their presenting sign could be death, and so does the patient have a family history of sudden death? Does anyone in the family have an arrhythmia, pacemaker, an ICD? Did anyone have a heart attack before age 50? Next slide. On physical exam, it's important to look for the subtle signs as well as those that strike us. Jugular venous distension in the pediatric population is an underutilized physical exam finding that could be indicative of heart failure. So just remembering to look at a patient's neck. I think it's easy to see tachypnea and increased work of breathing. Subtle crackles can also be heard, a wet cough, difficulty lying flat, persistent tachycardia for a patient who might come in with gastroenteritis who doesn't respond to a fluid bolus. A murmur may be indicative of an underlying congenital heart problem. A gallop is also indicative of heart failure. Hepatomegaly, poor perfusion, and looking at a pulse differential with low pulses in the, or poor perfusion and inability to feel pulses in the lower extremities, or a radiofemoral delay can be indicative of a coarctation or an arch obstruction. Next slide. When you suspect heart failure, the testing is really going to be guided by the history, but most patients should undergo the following: at least a chest x-ray to look at the cardiac silhouette to see if there's enlargement of the heart, pulmonary edema, and pleural effusions, an EKG to make sure an arrhythmia is not causing any problems that you're having, and also to look for signs of ischemia. Lab testing should both be diagnostic, such as troponins or BNP, which are not necessarily diagnostic but might help you guide you, and then other testing to help rule out a reversible cause, which we'll talk about in a moment. Assessment of end organ function is also very important to see how sick your child is, so getting evaluation of your renal panel and your liver panel as well. And then always an echocardiogram if you're suspecting of any of these things to both delineate the anatomy, assess chamber size, as well as your function. Next slide.
So if we go back to talk about our patient, RW, who was 2 months old when he presented and had a 4-day history of poor feeding, no family history of cardiomyopathy, and no family history of fevers. Next slide. When he was presented to the, this is his chest x-ray. He presented to the outside hospital, was given his bolus, at which point his respiratory status deteriorated, and a chest x-ray was done. Let's go to the next slide. This is fairly typical, although it's more pronounced than many other patients in terms of, you can see the cardiomegaly. You can also see some increased pulmonary markings in his chest x-ray, prompting the echocardiogram, which you can see on the next slide. And here you can see that there's decreased ventricular function. It's sort of just kind of rocking there in the chest. You can also see what we call smoke, which is that sort of appearance of grayness within the ventricle. What caught our eye on this particular echo was also the brightness of the mitral valve. So this is the mitral valve right here, and you can see that these chordae are brighter than the rest of the myocardium. Coronary arteries appeared normal on our initial study, but both the patient's age, the brightness of this papillary muscle, and the amount of mitral regurgitation prompted us to look a little bit further at his coronary arteries. Next slide. We did not cath our patient because we were pretty convinced he had an anomalous coronary artery based on our repeat echocardiogram. Had we cathed him, this is what his cath might have looked like. And here you can see the dye filling the right coronary artery, at which point it then fills through collaterals and dumps into the pulmonary artery on the left. This is kind of a fascinating disease. How sick the patient is and when they present depends a great deal on the pulmonary vascular resistance and how quickly or slowly it falls. And someone like our patient who presented at just 2 months, it fell relatively quickly. He did not have significant collateralization to maintain perfusion to his myocardium, which is why he then presented at that point time. This is so important to think about and to diagnose because it is one of the reversible kinds of cardiomyopathy that we see, and we never want to miss something that is potentially reversible. Next slide. This is a schematic of what an anomalous coronary artery looks like. Again, you see the right coronary artery coming off the aorta, and the left coronary artery can dump into the pulmonary artery. And actually, in enough collateralization, you can even present with a left to right shunt from your right coronary artery into your pulmonary artery. Next slide. And this is what RW's echocardiogram looked like after he had reimplantation of his coronary artery. You can see he's quite active, and that's why it's sort of moving around a bit, but obviously a marked improvement in his ventricular function, which is, of course, what we hope for. Next slide.
So I think all of this really drives home the point that it's very important to think about all the different causes of potential cardiomyopathy and not necessarily jumping the gun and saying this is a genetic or this is something that's myocarditis, and those are the two most common things that we see. Our testing should really include even those things that are maybe rare but easy to find answers to, so rickets, hypothyroidism, mineral deficiencies such as selenium, zinc, and carnitine, as well as inborn error of metabolism. And then more commonly, myocarditis, because there's potential reversibility with that. So testing for certain viruses, most commonly enteroviruses such as Coxsackie, adenovirus, HHV6, are important things to look for when you're first evaluating a patient with heart failure. And then, of course, because it is relatively common, genetic testing should also be considered, perhaps not on day one, but within that early period, because that testing does take a long time to return and can guide prognosis and counseling for family. Next slide. So I think it's important to move on to the management, and this is not going to be the cardiologist necessarily management. We'll talk about things that are applicable to the general pediatrician, the hospitalist, the person who's an emergency room physician as well. Next slide. So before we can really talk about management, it's important so that you guys can see what it is, how we classify stages of heart failure. So the American College of Cardiology and the American Heart Association have come up with a schematic. Basically, there's stages A, B, C, and D. A and B are those who are at risk for heart failure, and C and D are those who actually are suffering from heart failure. Stage A includes those who are at high risk for heart failure but have no structural changes or symptoms. So that might be the child of somebody whose parent has a cardiomyopathy. Stage B includes those who actually do have structural heart disease, but at this time are well compensated and they have no symptoms or signs of heart failure. Stage C, it becomes a little bit more concerning. These patients have disease and they actually have either had symptoms in the past or have currently having symptoms of heart failure. And then stage D is those who are critically ill with their disease. Those have refractory heart failure requiring specialized interventions such as mechanical circulatory support or IV inotropic therapy. Next slide. From a heart failure cardiologist perspective, we use these stages to help guide how often we're seeing them because they are those with a higher stage are more critically ill and we should be seeing them more often. So just so you guys can get a sense of how often we see these patients, because you're probably seeing them in the interim and want to know, when are they going to see their cardiologist next? What testing might be they doing at that time, which would help your care and guidance of them as well. So stage A, those who don't have any symptoms or are just at risk, would probably just do some sort of routine imaging, either an echo or MRI, just depending on what their diagnosis, what disease they're at risk for, as well as an EKG, somewhere between every 1 and 5 years. Those with stage B, so those who have some structural heart disease but not symptomatic from it, will be seen much more frequently. So depending on the degree of, they may have severely depressed function or moderately depressed function and not be symptomatic. Those we might want to see much more frequently, about every month or so. Or they could have completely normal structure but have non-compaction or trabeculations that we're watching for, and those would probably only see once a year. Again, the testing that we would do for them included some form of imaging, an EKG. We'd want a Holter monitor to rule out a cold arrhythmia or to assess for the burden of arrhythmia, as well as exercise stress tests to make sure we're not missing any acute ischemia or inducible rhythm issues. We'd also be seeing them because most of these patients will be on some degree of medication and they'll need ongoing medication assessment and assessment of their end organ dysfunction with laboratory testing. Next slide. Stage C, much sicker, similar testing, but much more frequently to be able to see them. And stage D is very likely to be inpatient or be barely outpatient, where they're seeing this either a couple times a week or potentially once a week. These are patients who might have a ventricular cyst device. Next slide. In between these visits, if there's anything that you guys are ever concerned about, we're always happy to see them sooner, and we appreciate communication from you guys are our eyes and ears out there as well. For patients with cardiomyopathy, any new or unexplained fatigue or change in exercise tolerance, that should prompt a referral back to us or a conversation. New palpitations or new chest pain, or poor weight gain for infants or even older patients. And those with congenital heart disease, if you feel like they're having any of the same symptoms or any other concerns, change in their oxygen saturation or any other things that you're not used to seeing or wouldn't expect, to give us a call. Next slide. So this is that same slide talking about the pathophysiology, but in this situation I've sort of added a different areas or targets where we do target medications. So the first thing we'll talk about is beta blockers, which you can see. I'm going to have Shadon come back to the slide between, sorry. So beta blockers, you can see, decrease the renin, kind of prevent the renin-angiotensin-aldosterone system from happening, as well as improving or reversing cardiac remodeling. Next slide. So they exert a primary effect on beta-1 and beta-2 receptors that are present in myocardium and peripheral vasculature. Beta-1 receptors increase contractility, chronotropy, and vascular tone, whereas beta-2 have a vasodilatory effect. The beneficial effects from heart failure come from that ability to counteract the maladaptive neurohormonal activation in chronic heart failure. In adult studies, beta blockers, patients with heart failure who are on beta blockers have actually been shown to have an improvement in their ejection fraction over time, promotion of this reverse remodeling, and have had actually a decrease in mortality. And those studies actually specifically looked at the drugs metoprolol, bisoprolol, and carvedilol. Unfortunately, in pediatric studies, the results have been relatively mixed, but that has not stopped us from continuing to use this as one of our first-line therapies. There's the inherent limitations in pediatric studies. It took 4 years for them to get the first trial going and enrolling enough studies, enough patients to make it a worthwhile study. So I think there's probably benefit out there, as most heart failure doctors do. It's just that we aren't able to demonstrate it due to their limitations in randomized control trials. Next slide. Beta blockers, I think this is important to know because our patients are going to be on these and then they're going to come to you for their primary checkups, and if the parents complain about any of these symptoms, it might change the way we would view their medication or whether we need to do a dose adjustment or switch them to something else. So if you're seeing any of these side effects, it might warrant re-referring to cardiology sooner than usual. Overall, beta blockers are very well tolerated with minimal symptoms. Those who have reactive airway disease or asthma might have some bronchospasm, so if they get diagnosed with that in the interim, after they've gotten started on the medication, it might be important to let us know. Also, patients with diabetes can become hypoglycemic from their beta blocker as well. Bradycardia is an expected change and usually well tolerated. A patient who has some degree of mood or psychiatric issues may also experience a significant change in mood, which might prompt to a different medication. And constipation is a common side effect as well. Next slide. This is just also referring to the Renin-Angiotensin-Aldosterone System, as we mentioned before. I'll leave this for reference for those who want to come back to these lecture later. Next slide. ACE inhibitors are other great drug that we have. As you guys probably remember, the ACE inhibitors block conversion of angiotensin 1 to angiotensin 2. Angiotensin 2 is a potent vasoconstrictor with direct action on vascular smooth muscle and central effects on vascular tone. It promotes volume expansion by enhancing the production of aldosterone and antidiuretic hormone, and has actually been implicated as a cause for cardiac fibrosis. In adults, there's been a survival benefit in patients who have heart failure with reduced ejection fraction, and therefore it is recommended for all patients with heart failure and reduced LV ejection fraction, unless there's a specific contraindication. In pediatrics, we have limited studies, but we've had mostly a positive effect, and so we also use this as a first-line therapy. Next slide. There are a few side effects that we do watch out for. One is a kind of a dry cough, and that's due to the unopposed production of bradykinin. Very, very rarely will we see angioedema, and hypotension is also very rare and usually dose-dependent. If a patient's not tolerating an ACE inhibitor, we may consider switching them to an angiotensin receptor blocker. This is related to the ACE inhibitor as it exerts effects on angiotensin 2 receptor. Theoretically, it has higher specificity for the anti-angiotensin II effect, which helps you with the lack of ACE escape, which is a phenomenon where aldosterone and angiotensin II serum levels increase despite ACE inhibitor use. Next slide. For adults, they've reserved ARB use for those who have had current or prior symptoms of heart failure and reduced LV ejection fraction, but who cannot tolerate an ACE inhibitor. In pediatrics, we have no studies and therefore no recommendations, and therefore you'll see this used very infrequently. But the potential benefit is with side effects and that there's a mitigation of cost compared with the ACE inhibitor. Next slide. Sometimes you'll see patients on digoxin as well. This is a cardiac glycoside that increases sarcoplasmic calcium concentration via inhibition of the sodium-potassium ATP ACE pump. It helps counteract the neurohormonal activation seen in patients with heart failure as well. In adults as well as in pediatrics, this was a much more common drug in the past, but more limited after we've really seen no improvement in mortality compared to placebo. And there's also been fears due to the fact that it has a very narrow therapeutic window with high risk of digoxin toxicity, which can promote arrhythmias, confusion, vision changes, and gastrointestinal symptoms. Therefore, this has not been used very often, although in the pediatric population, there's a question of whether it benefits patients with a large left to right shunt. Next slide. Diuretics are one of our mainstays of therapy, and this is really to treat symptoms. Our most common diuretics are Lasix and Diuril. They're really aimed at alleviating the symptoms of fluid overload and sodium retention. There's no data regarding long-term benefit on mortality in adults or pediatric patients with heart failure. There is a side effect of our electrolyte abnormalities with a contraction alkalosis, and with excessive use, you get volume depletion, renal insufficiency. Next slide. You may also see that our patients are often on spironolactone or its sister drug, eplerenone, and it's not usually actually for its diuretic potential. It actually has a very weak balance on the fluid status, but it does have an ability to reduce angiotensin II, and therefore there's been observations that have shown that it has improved cardiac remodeling and has potential for antifibrotic properties. Most of the studies in pediatric populations are in Duchenne muscular dystrophy patients, but again, those are pretty limited studies, although adults did find in 1999 that there was a survival benefit with those who had symptomatic heart failure with a severely reduced ejection fraction. The biggest side effects for spironolactone, it says it's about up to 10% adult males, but that was in clinical trials and not typically what we see in the clinical application of the medication. It's much more rare than that, but gynecomastia can happen. More commonly, we do see some degree of hyperkalemia, but often it's balanced out by our other diuretic use, and so not clinically detrimental. But we do frequent lab monitoring for these patients. Next slide. Next slide. So what do we do when oral heart failure therapy doesn't work, or when we're starting to approach Class C or Class D? Cardiac transplantation is one option that we have for these patients. And just like it sounds, and you guys all probably know, it's basically taking out the diseased heart, removing it with replacing it with a donor heart. This slide is just meant to demonstrate the different connections, SVC, IVC, aorta, and pulmonary artery, all of which can be areas down the line you have to watch for anastomotic surgical, potential need for surgical intervention on the anastomotic site. Next slide. Cardiac transplantation is really indicated for those who either have congenital or acquired heart disease, who are either dependent on mechanical circulatory support, IV inotropic support, have anticipated survival less than 1 year, or have a high risk of sudden cardiac death. Another population that unfortunately may need retransplantation is those who've gotten transplanted before because of the development of coronary artery disease, which we'll talk about in a second. There are very few absolute contraindications to cardiac transplantation. One of them would be that if you had a systemic disease that was anticipated to limit the long-term survival because of the shortage of donor hearts. These might include a malignancy that was within the first 2 years of diagnosis. Morbid obesity is more of a relative contraindication, but it might require some attempts at weight loss prior to listing them. Multi-organ dysfunction is typically absolute contraindication, as it's very unlikely that they're a little too sick to survive, and HIV as well. The second absolute contraindication is fixed pulmonary vascular resistance with a pulmonary vascular resistance index greater than 6. And for these patients, they would probably need a heart-lung transplant. Active infection, just because you do need to immunosuppress afterwards, and so they're at risk for even furthering that. And then psychosocial factors have always been considered a contraindication, but rarely is actually used in the pediatric population as a true absolute contraindication. But the patients do go through a thorough evaluation prior to being listed. Next slide. Long-term, the things that we watch out for cardiac transplantation: surgical complications, as I talked about, primary graft failure, which is failure within the first 30 days of an unknown source. Infection, particularly bacterial and viruses, as those are most common, but patients are often on prophylaxis for PCP as well as cytomegalovirus, as these can be pretty detrimental for the immunosuppressed patient. Rejection comes in two main flavors: acute T-cell mediated cellular rejection, which is what we probably worry about the most often, and then antibody-mediated rejection, which is B-cell mediated. We always worry about that one because they tend to come in thicker, but it less often happens. Coronary allograft vasculopathy is a diffuse inflammation of the coronary vessels that narrows the lumen of the vessel. Unfortunately, this is not amenable to stent placement or other interventions, and really the only real option for these patients is cardiac retransplantation if significant enough. And those patients who develop this disease are at high risk of sudden death. And this is unfortunately something that is the most common reason for a graft to fail long-term. Patients who have undergone transplantation are also at higher risk than the standard population for malignancy, most specifically post-transplant lymphoproliferative disorder, which is triggered often by Epstein-Barr virus and then acts like a lymphoma. And then a potential complication is that these hearts don't last forever. The average kind of lifespan of a heart is somewhere between 15 to 20 years or so at this point in time, and so most of our children, being so young, will often need a second transplant during their lifespan. Next slide. I think the medication side effects are important for those out there in the community to know about, because our patients are on a lot of medications, and parents may call you guys regarding these as well. These are the maintenance immunosuppressive medications that they're on with their side effects. Calcineurin inhibitors include tacrolimus and cyclosporin. Tacrolimus is our go-to drug. It tends to have a more favorable side effect profile, but can cause nephrotoxicity. And about 1 in 10 patients who require pediatric heart transplantation at some point in life will have either end-stage renal disease requiring renal transplantation as well. Patients will often suffer from hypertension, hirsutism. Hirsutism is really more with cyclosporin as well as gingival hypertrophy. Most of our patients waste magnesium and will be on magnesium supplementation. They're at risk for seizures, and some of them will be at risk for diabetes as well. Antiproliferative agents include CellCept, and that causes neutropenia and sometimes GI upset as well as diarrhea. mTOR inhibitors are a newer class of drug that is thought to help prevent against coronary disease, but comes along with the side effects of impaired wound healing and mucosal ulceration. And that can be very significant in a patient who's immunocompromised and at risk for infection. Corticosteroids, as we all know, you love and hate. They help us, but they also have a lot of side effects, including hypertension, diabetes, osteoporosis, weight gain, acne, headaches, and water retention. Next slide. While you're waiting for cardiac transplantation, patients are ranked there's 4 different statuses or categories of severity of illness, basically, as guided by the United Network for Organ Sharing. Status 1A is the sickest patients. Most of the time they are inpatient, with the exception of those who may have a mechanical circulatory support device, and they could theoretically be outpatient. Next slide. Status 1B could be inpatient or outpatient. They either require infusion of 1 or more inotropic agent, but they don't qualify for status 1A because they don't have the diagnosis of underlying congenital heart disease. Or those patients who are really young with hypertrophic and restrictive cardiomyopathy. And this is because we don't have a lot of good options for that specific population. They're not good, bad candidates, and inotropic therapy doesn't usually help them because they suffer from diastolic dysfunction. Status 2, most of those patients are outpatient, and they need a cardiac transplantation, but they don't meet the criteria for 1A or 1B. And status 7 simply means that patients are inactive, meaning that they're either too well for transplant but we haven't taken them off the list because we're not sure that this will be a sustained improvement in their function, or they're too sick for transplant, so they have an acute infection and organ dysfunction that might compromise a new heart. When you're status 7 and inactive, you do not accrue additional time. Next slide. So while you're waiting for cardiac transplantation, I guess what I should have mentioned is for each of those statuses, is you could get a heart the day that you're listed, or you could wait months to years. Average wait times for status 1A or sickest patients is weeks to months. For status 1B, could be years, and status 2 could definitely be much longer. And so the field of mechanical circulatory support has really developed to try and help those patients so that they can stay alive to receive their transplant. Next slide. I really just want you guys to understand the indications for mechanical circulatory support. So these are patients who are not doing well despite being on IV inotropic therapy or have a disease that's not necessarily amenable to getting better with inotropic therapy. And we use mechanical circulatory support as a bridge to something. So either a bridge to recovery, and this would be the classic patient would be somebody who came in with myocarditis with severely depressed function, who had liver or renal dysfunction, and was not doing well on their inotropic therapy, and so then they got a temporary device to bridge them until they got better and their heart recovered. We use it as a bridge to transplant, so those patients who are not doing well, who need a new heart, but can't wait like that just with inotropic therapy. We also use bridges as bridges to bridges, meaning if you have potentially a recoverable illness and you want to try it out to see if a VAD will help them before you want to commit to a long-term device. Sometimes we'll use a bridge to bridge. Additionally, a patient may not be a transplant candidate, meaning they haven't completed their transplant evaluation, which is a very long process, or they may have some other reason that they're not a current candidate but maybe a future candidate. And so sometimes we'll place devices as bridges to decision. And then in the adult population, this is becoming a lot more common, but a bridge to destination therapy, meaning that this is the end. This is just to prolong their life and their quality of life, but there is no transplant at the end of this. Next slide. This is a schematic that sort of demonstrates that. For those patients who require mechanical circulatory support, if they do not require pulmonary support, then they're candidates for VADs. And a ventricular assist device or a VAD can either be in a short-term device, such as a PediMag or a Centramag or a Rotaflow, which I'll show you pictures of in a moment, or a long-term device if we do not think that they have a short acute process that's not going to recover. A short-term device, as I mentioned, is ideal for the patient who has myocarditis that we think is going to get better or has a high probability of getting better, or even for the transplanted patient who might have acute graft rejection and just needs some temporary support while we're able to help them out with that. And that's where this BTR, or bridge to recovery, comes from. For those who start out with a short-term device, so potentially a myocarditis, we think they might recover and then they don't show any recovery, and if the decision is made that they need transplant, we may then bridge them to a longer-term device. Longer-term devices in the pediatric world, we really only have two probably great devices, and even they have limitations. And they're mostly dependent on size. So the smaller patient is the Berlin X-Core, which I'll show you pictures of in a moment. And those are patients who have BSA of less than 7. And then a newer technology is the Heartware, which is a BSA of greater than 0.7. And we use these long-term devices as a BTT, or a bridge to transplant, or a BTD, or bridge to destination. Next slide. So bridge to recovery, so these are the temporary devices. These are just a couple different schematics of what they look like. They're pumps that are centrifugal pumps, kind of continuous flow, and they are come in two flavors. On the left side of the screen, you'll see the Mackay makes one that is the Centramag, a PediMag. Centramag and PediMag are just based on the different sizes. And then on the right side of the screen is basically its cousin. It looks the same, it's just a different, and functions the same, it's just a different company that makes it, Thoratec, and that's the Rotaflow device. Next slide. More durable devices are ones that we use for longer term, and those are bridge to transplant, destination therapy, or bridge to decision. This is an example of the Berlin heart. In the top left corner, you can see the inflow and the outflow cannulas, and that's actually the patient's blood that's being circulated through. The middle is a picture of a child sitting on the driver or the controller for this, which is called the IGUS, and you can see how large it is. So one of the important things, while Berlin hearts are great in that they come in a variety of different sizes and can fit most children, the biggest problem is that because we do not have a small controller, these are not devices that we can send patients on. It's not FDA approved. So these patients will be inpatient until they have typically their transplant. This is not a destination therapy. The next slide does demonstrate a potential destination therapy. Next slide. This is the heartwear device. This is commonly used in adults and often in our older kids, those with a BSA of greater than 7. This is also a continuous flow device. You can see the device is pretty small, fits in the chest of many children, really is inserted into the apex of the heart where the blood is removed from there and recirculates out to the aorta, taking over the work of the native heart. You can see in the schematic, the drawing, that's the controller that's kind of in a belt around his waist, and so patients can move around freely when they recover, and many patients go home with this device, either to continue to be listed until their heart comes, or in certain populations, such as those with Duchenne muscular dystrophy who are not candidates for transplantation, as a bridge to destination. And many adults are actually on destination therapy with the hardware. Next. The Syncardia is a newer device. This is a total artificial heart. This is more of an adult device in that it's too large right now to fit most children. You have to be pretty much adult size. The guy in the middle was on it for about 2 years of his life. The drivers, when you're in the hospital, or the controller, is the big cart in the middle, and then when you go home is the Freedom driver in the top right-hand corner. It's much smaller, but it does go into a backpack. The bottom right-hand corner describes the 2 different sizes, the 70 cc, which is the one that's commercially available for most centers to use, and the 50 cc is the smaller, and that's on trial to try and help out some of our smaller women as well as some of our pediatric patients. And this really requires removing the ventricles of the heart and replacing it. So this is a complete, there is no way out to this. Once you commit to this, either the device gets removed and the patient dies, or they make it to transplant. Next slide. Potential complications of bad therapy include pump malfunction, infection. As you can see, most of those drive lines were coming out of the patient's body. Hemolysis from the shear stresses. These patients require anticoagulation, and so there's a very fine balance between bleeding and thrombosis. Thrombosis obviously can result in stroke and potentially neurologically devastating events. Renal infarct, splenic infarct, or ischemia of extremities. Air embolization is possible. And then aortic insufficiency is something we watch for those patients who are going to be on it for a long period of time, as it sort of sucks in the valve as it's pulling out the blood, and that's something patients are at risk for. And something that we're starting to learn more is that there's quite a bit of psychological impact, especially for our teenagers and children who are on these devices. And trying to figure out how to optimally manage that for these patients is challenging. Next slide. So you can see that we have come a long way in the field of pediatric heart failure. One of the not surprising but not initially thought about results of having all these devices is that most of our transplant patients are waiting longer for their transplants. Our outcomes from transplant, however, remain excellent. I think the biggest challenge remains the one that is out in the community, and that's identifying the patients in heart failure early, because it's so easy once you know what they have, but it's it can be so similar to so many of the other presentations that our pediatric patients have. So I think we have a few minutes remaining, and we'd be happy to take any questions that anybody has. It's hard to tell if anyone has questions. Tucker, could you help us out? Well, it doesn't look like there's any more questions actively right now, but I do want to remind you guys that there are these presentations are going to be posted, and perhaps Tucker or Shadon could talk about that in a moment, where they'll be posted for further review later if you want to refer back to it.
So Dr. Khan and I are available at any time for any questions that you might have, either regarding patients that we follow with you or patients that you're not certain what to do with. For example, that patient who has one family member, would you screen everybody and what's the best thing to do? And we're happy to help in any way.
And,
hi there.
Oh, hello.
This is Tucker from marketing. I was just going to let everybody know that after the presentation, I will be posting the recording online, and I will send all of you an email to the address that you signed in with, letting you know that it's there. And that same website where it is, there will be other presentations posted. So if you have any questions regarding cardiology or one of the other presentations, please don't hesitate to reach out and ask those.
Thanks, Tucker.
Thank you guys all for coming.